We're back with part two. It's Cheryl Grainger and I, Debbie Evans, doing a post-mortem of the latest MHRA board meeting. And hopefully you'll have caught up with part one. But we felt that, well, a particular section of the board meeting was taken up with the yellow card. Now, for those of you that haven't caught up with part one, the MHRA are the medicines regulator. They hold a board meeting every 3 months, or at least should. And Cheryl and I always end up going to watch it because you can get tickets, they're free. You can get tickets from Eventbrite and you can join via Zoom and watch what's going on. You can't participate, although you do have a chat box function, but you can't participate. And Cheryl and I have been to every single one of these MHRA board meetings, and many of us know that we work together. We've worked together for quite a few years now, Cheryl, all through goodness knows what, and anything pharmaceutical. I always go to Cheryl for because she is the pharmaceutical expert as an independent training consultant. And as you know, I'm a retired nurse, ward sister, and I'm a bit gobby. Well, we're both a bit gobby, aren't we, really, Cheryl? We're like the Cagney and Lacey of the MHRA. Yeah. So we thought that we'd do this in two separate parts because the yellow card segment took up nearly 40 minutes and questions at the end of the meeting. And we felt that it was so important what they said that we should make this a special. So let's start off with, and let's just remind ourselves actually that Dr. Alison Cave is the Chief Safety Officer at the MHRA, and she's actually the highest paid. She is in receipt of, is it nearly £200,000, Cheryl?
Bit short of, yeah.
Welcome, by the way. Thank you for staying around, hanging around to talk about yellow card. But yeah, it is, isn't it? She's the highest paid.
Yes. Well, we don't know what Harnden's going to be on, do we?
No, true. Dame June Rain, she was on 100 and...
I think she was on about 190. No, 170. And
170.
90. But I mean, Talon will probably be on more than anybody, won't he? It'll be historical that people are out of sync with each other. So
yeah.
Person coming in, they probably can give him more.
Yeah, we'll be keeping our eyes on that too. But in this board meeting, which was Dame June Rain's last board meeting, we had a big agenda item on yellow card. And it was basically, what is the yellow card? What's the yellow card for? Where's the yellow card going to? What are they doing? Everything about the yellow card. And I sat there, Cheryl, honestly, I just wanted to cry. I just wanted to cry because they were saying stuff. Well, let's just talk about it. Let's talk about the yellow card. So they want to increase awareness and improve awareness to improve patient safety. Yellow card. It collects and monitors side effects of medicines and devices. Now, medicines, everybody's familiar with the term medicines. Let's talk very quickly about devices because you've mentioned devices in part one. But devices, many people will think, perhaps something like a Neuralink, a device, or a cochlear implant, something that's actually attached to your body. But actually, a device is something that diabetics may use to test their blood sugars, for example. It can be a PCR test. That's a device as well. So an asthma inhaler is a device. So the word device and a prosthetic arm or a prosthetic leg is a device. So it's a big term and it covers a lot. And we're seeing more and more devices coming into the marketplace. And of course, they're going to be barcoded. Everything's going to be barcoded, including medicines. So the yellow card system was, well, you tell us, Cheryl, when was it? Go back to thalidomide.
Yeah, it all goes back to thalidomide and the Medicines Act 1968, that coming into play. And that stated, two of the things it stated, amongst others, was that you couldn't release a medication that was just based on animal studies. And secondly, whenever you were advising something for the pregnant, you had to have the safety studies to prove that that was okay. So those two things came in, and then there was a series of committees that developed eventually into the MHRA. And 60 years ago, we got this yellow card system, which allowed people, to start off with, it was just doctors, to be able to report any side effects. Because that was the thing with thalidomide, you didn't have computers then, but they actually had stopped the whole thing within 5 years. Don't forget, with the COVID-19 vaccines, this is the 5th year.
And they're still rolling it out.
Yeah. So, you know, we're kind of catching it up. And we have had a lot of effects reported. The yellow card system had never seen such numbers. So the whole thing about, I mean, Alison was obviously remote. So she was sitting there with some of the board showing, and she had the other half of the screen for a long time. So it really emphasised
it really did
what she was saying. And perhaps she's not around for June's leaving do afterwards, I don't know. I don't understand why they keep going on and on and on about trying to get more people to report in when they're doing nothing with it.
I do. I've sussed it out. I've sussed it out. Let's go back then to what they've actually said, because some of the things that I was picking up, and my radar was like do 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 the whole way through, and I just wanted to scream at the screen. I really did. What shocked me was we had Alison there, but we had this other lady that came in called Stephanie, who was talking about the yellow card scheme as well. So they seem to be talking about the fact that 2024, they had the most yellow cards for adverse reactions for medicines ever. And they had over 100,000. So let's not talk about the vaccines just for a second. This is 2024 and this is medicines. And they were going, we've had the highest ever, 100,000. And I think it was 34,000.
150,000 for the yellow card and about 34,000 for devices.
The devices. So, and then they were talking about the fact that they want more. They want more yellow cards. That's not enough. It was almost like, we've only had, but in COVID, we had over 500,000 serious adverse. Whoop, whoop, yip, yip, hooray, crack open the champagne. We had 500. Where was I going wrong here? They were saying they want more yellow cards. And like you, I'm sitting there going, but they're not doing anything with the ones that they've already got. And then I suddenly worked out, Alison said, this has been immensely, that was her word, not mine, immensely useful understanding safety and efficacy with the COVID injection, 500,000. It was immensely useful. And she wants to see a quadrupling of yellow cards, 10 times the amount in volume.
That's asking for side effects.
One yellow card is one too many, right? But no, they want as many as possible.
I mean, the question that people were asking right at the very start of yellow card increasing when the vaccines came out, what is your level for taking this down? So if you got 50 deaths in the past, no more than 50 deaths, it was taken down. Doesn't matter if it's rolled out to billions of people. 50 deaths is too much. And don't forget, Pfizer, within the first 3 months, that post-marketing study that was included with the documentation, they had 1,223 deaths. So it should not have got off the ground, according to what had happened with other vaccines in the past. And this is the thing, they're not acting on anything that they're seeing. I mean, you had more adverse reactions reported for the Pfizer vaccines than you'd ever seen in the last 30, 40 years of all vaccines added together.
Well, Graham Cook actually made quite a valid, Graham Cook, who was the chair in standing in before Anthony Harnden, he said, are we assuming more is good? And should we be setting a target? I mean, this is like, but then I suddenly realised, actually, June Rains said that the yellow cards weren't a strong form of evidence. She said that at the board meeting. I actually wrote it down. It's on my shorthand. Haider, I think it was Haider Hussein, said that the yellow card sounded more like a football card and he couldn't work out why it was called yellow card and we needed to rebrand it. And
it was because it was actually printed on yellow card at the
yeah,
back of the BNF and MIMS and everything, so that you could easily get to it when you had to send it in by post.
yeah. So as I was listening to them and they're talking about they want more yellow cards, we want more. I'm sitting there thinking, this is ridiculous. And I suddenly the penny dropped. And of course, every yellow card they get is ka-ching. It's money. It's research. It's data. And I suddenly thought, oh my goodness, the MHRA are not feeding back to anybody. It's of no benefit to the patient. So I put a question in the chat box and I asked, because at the end of the meeting, any questions that are asked to do with agenda items are asked at the end of the meeting. And I know that you put a question in and it hasn't been answered. And we'll come to your question in a minute. But my question was, what benefit is it to the patient for sending in a yellow card? Why should they send in a yellow card? What should they expect back? Will they get some advice? Will they get some treatment? Will they get, what can they get back? And what I was really shocked at was actually patients, vaccine injured, if you're listening, don't expect anything, because there is no responsibility for the MHRA apart from acknowledging your yellow card. You should receive an email to say that they've received it, but then they'll send you a link. And this is what Alison got really excited about at the end of the meeting. Oh, we send them a link and we show them the journey of their yellow card. Well, that journey doesn't involve them at all.
Don't forget that when you actually go on to fill in a yellow card, it gives you 4 points. It states that you can't assume that your side effect is linked to the treatment. The condition you've got, which is a bit strange to say with COVID vaccines because you didn't have anything wrong with you generally. So the condition you've got may be causing the same symptoms. Most people take the treatment and don't have any problems whatsoever. It's very rare to have a side effect. And there's a fourth thing, and I've forgotten it. But all the time, they're trying to say this isn't related to the thing that you're reporting it on. There's no, considering their pharmacovigilance and are supposed to be looking at risk, and that's the same from the EWG and the CHM's committees. They're all supposed to be looking at risk. They're not seeing anything, because they're convinced, and they never do causality. So right at the beginning of this, Jessica Rose did the Bradford Hill criteria, and she showed all of the criteria could be shown to be met. And Peter McCulloch's done the same thing. And, people...
Let's just rewind for a sec. Tell everybody what the Bradford Hill criteria are.
I mean, there's got to be a way of trying to look at causality. So things like the time lag. So most deaths happened within day 1, day 2. And it's a whole series of things like that, biological things and scientific things that you can actually get data on from your initial results to see whether there is a causal link. And the WHO approves of the Bradford Hill criteria, which is why Jessica Rose started using it. And she said that the WHO accepts causality if 5 out the 10 criteria are actually met, and she met all of them from her analysis that she did, and it's all been ignored.
Who is ignoring them?
Well, the regulators.
And who WHO. They're ignoring their own criteria. And I also noticed as well that with the yellow card, somebody's putting in a yellow card. Where is that data going? It's going to research, it's going to academics. And for those of you that are watching, even if you're not putting in a yellow card, and if you've registered with a GP and your GP happens to be part of the CPRD, which is the Central Practice Research Data Link, this is a system that operates between your GP surgery and the MHRA direct. Now, all of your data, unless you've opted out, will be going direct to the MHRA, anonymized probably, but it'd be going to CPRD. So it might be worth asking your GP, are you signed up to CPRD? Because the MHRA want every single person's data, as much data as possible. They're like data hungry. And one of the questions at the end of the board meeting, because again, you're shoveling data at them. It's almost like, I've gotten to the point, Cheryl, to be honest, where I'm thinking, should people be putting in a yellow card? Because if they are putting in a yellow card, all they're doing is feeding the monster. They're feeding research. They're feeding pharmaceutical companies. Their data's being sold. Because what I think should be happening at the very least is that if you get a yellow card from someone, you go, oh my goodness, that person suspects that they may be having a reaction to this drug. We've now officially recorded this with the MHRA. Now we need to make contact with their healthcare provider, their GP, or whoever their consultant is, with which to be able to say, look, we've received a yellow card from this patient. Were you aware of it? This has now been recorded as a suspected adverse reaction, so that the doctor or the physician or the clinician actually knows there's been some form of formal recognition from the MHRA. So I was shocked when obviously somebody from the NHS had put a question in at the end of the board meeting and said, would it be possible for areas to know how many adverse reactions had gone on in, I don't know, London or Birmingham or Manchester or wherever, and what those reactions were. And Alison Cave was sort of reluctantly scratching her head and saying, well, we do have to protect patient confidentiality. Well, you shouldn't have any of the patient's data anyway, Alison. And what you're saying is that basically you don't want to share your data with anybody else. We've got to share it with you, but you don't want to share it with anybody else for the benefit of us. See, I'm starting to get fired up now.
I mean, they're supposed to share all the data with the pharmaceutical company.
Well, that's no good.
I know. And they're supposed to share it with the international group that look at all side effects worldwide. And they seem to have been very quiet. There doesn't seem to be anything that's in that regard. But
Alison Cave said, I asked her directly, what are the benefits to the patient? Well, and she said it was for the population. The benefits are for the population. The people that are putting in yellow cards with vaccine injuries, they're contributing to the general picture of the global population. There's no help coming to them.
I know. The Carl Hennigan's Substack had a lady who'd written in, whose good friend had died because of the vaccine. And she was like a dog with a bone. She wouldn't let it go. She asked the family if she could follow up on the yellow card. She could fill it in and send in all the information and what have you. And she wouldn't let the MHRA go. She kept asking questions. And the MHRA finally got in touch, not with the family or with her, to find out more detail. It took 2 years and 2 months to get in touch with the healthcare practitioner that was involved in it.
But we know, Cheryl, that people have died.
I know that they've died. What I'm saying is there's no follow through. And that's what's frustrating to people, because it's a difficult form to fill in, especially if you've lost somebody, and then you've actually got to sit and wait for something that never comes.
Well, Amanda said during the meeting, and I quote, she says, if a company has a new drug, is there a marketing strategy for the yellow card? It's like, oh, well, we'll probably expect X, Y, and Z adverse reactions. Are we prepared for them? It's almost like they're rolling drugs out now that they know are going to cause serious adverse reactions. So they need to be prepared for them before they actually happen. And the other thing that I noticed was that they want to start marketing yellow card. They want radio campaigns, they want media campaigns, they want everybody to be aware of the yellow card. That's if it stays as a yellow card, but they very much want as much data as possible. And it absolutely shocks me. It did shock me to the core when I saw the cold and callous way that they completely disregarded the patient.
And
The
don't forget,
patient.
the patient was the most important thing. They declared it at the beginning of the meeting. They were doing this for patients. They were accelerating everything for patients. Then we're going to dump you, not do anything with you if you have a problem. I mean, things like the thrombocytopenia that started developing, the VITT at the beginning with the AstraZeneca. There was a professor, I think she was from Scotland, who noticed what the problem was. And it was completely different from what she'd seen before. And then she got together with some European medics who'd noticed the same thing. And they wrote all over the place to tell people what had happened. And, you know, the MHRA would have been informed and they do nothing about it.
No, they're not there to do anything about it. They're there to ignore it. And I think that's what we have to get our heads around.
I know.
You know, the
It's totally
MHRA.
logical that you're asking for yellow cards to be filled in and doing nothing with it when that is somebody's life or somebody's severe illness. And that's the thing that is, you know, very, very disturbing.
Well, we know that we've seen Baroness Julia Cumberledge, who wrote that damning report, Do No Harm, of the MHRA on mesh and sodium valproate. We know that she said that yellow cards, basically, she was told that they went in the bin.
We've got her on video saying that.
Yeah, we've actually got her on video saying that they literally go in the bin. So they are of no benefit. And this is the thing, you see, the public, you know, those of you that are vaccine injured that are watching, or those of you that have got, let's not forget, 1 in 6 people in hospital right now are in hospital with a serious adverse reaction from a drug, whether it be prescribed or non-prescribed, but they're there for a serious adverse reaction. And those of you that are watching with vaccine injuries and you're putting in your yellow cards and you're expecting a callback from the MHRA, or perhaps you're expecting some advice or, you know, some liaison with your GP or your hospital, forget it. That's not what they're there for. They are there to service and enable the pharmaceutical trade, the industry, the the whole lot, the biotech industry. That's what they're there for. They're not there for us. They're not there for you. They're just not. So what else did we need to tell people about the yellow card? Is there anything that we've missed about the yellow card? Because I just think that the relevance of that meeting and June's last meeting, and she's saying, well, it's not really a strong form of evidence, the yellow card. What we need to be doing actually is relying more on papers, academic papers and scientific evidence.
That's the 4 strands, isn't it? There's the yellow card, there's the yellow card monitor, which June was singing the praises of in terms of pregnancy not so long ago, which is why I've taken her up on that. And then there are the academic epidemiological studies and what have you that come into the second 2, which they don't seem to have done much in terms of looking that data up when FOIs have been put in. They've not published the monitor at a proper time frame. And that actually is more accurate than yellow card. But yellow card went off the scale, and that it didn't even produce a reaction. But they're all in cahoots because everywhere globally, every regulator had the same sort of reactions, the same sort of increase in numbers with their equivalent of yellow card, and didn't do anything about it.
I think, you know, Cheryl, the one thing that whenever we're on the phone together, one of the things that you always say is mRNA should never have been rolled out in the first place. And the pipeline, as you've been looking at it and as I've been looking at it, you know, we've got manufacturing, we've got Stargate project, cancer vaccines being manufactured, mRNA cancer vaccines in 48 hours by AI. Isn't that reassuring? We've got those being manufactured and a load more in America. We're also doing our own manufacturing. We've got Moderna and we've got the new vaccine manufacturing complex that's opened as well. So clearly mRNA and other novel
the third biggest
antivirals.
Third biggest hub globally for cell and gene technology.
Wow.
And a lot of it's up the road from me.
So, and a lot of it's going on in Cambridge for cancer as well. We've got pockets in the country. What's going on in your area?
Well, it's the old Glaxo building that was built on Nebworth House grounds. So they sold some land in the 90s. That was going to be their AIDS research centre, which didn't produce anything. There's quite a few people around here who obviously took early retirement or redundancy, and that was kind of beginning to close down. And then they got into Cell and Gene Catapult, and they're extending the buildings. They're building all little units because, of course, these new biotech companies have just 10 or 12 people working in them who are coming up with the idea. And then right in the middle of Stevenage, we used to have a Marks and Sparks. They knocked it down. They built flats and commercial all the way around the three sides of it. What was the car park in the middle, that's now become Autolus. And Autolus is a cell and gene therapy unit. So it's manufacturing. So as Headley will tell you, you've got lipid nanoparticles that are supposed to be at minus whatever it is, degrees, 90 degrees, in liquid nitrogen anyway, coming down in trucks to go in the back of this thing in front of a load of flats. And when I chased it up with the council, they got about 60 million, or they were involved in the investment of 60 million in this unit, which apparently is green because they made it up in Newcastle in units and brought it down. So apparently Newcastle making it doesn't affect the carbon when they bring it down and put it together. Anyway, that's a load of nonsense. So it's all such a con. And they said that it's all right, health and safety, health and safety is always supposed to be so well looked after, that they've got cages that the liquid nitrogen goes into and it's all locked up. And you just think, well, there's a car park under that. We've only got to have an electric car that goes up and they'll think of it.
Wow.
And I don't know whether those people who are living around it know what they're
No.
in the middle of it.
Well, I mean, seriously, I say to people, look around on your industrial estates. You don't know what's springing up. You don't know what's behind you, whether it's a lab, a laboratory. And now, apparently, we've got 12 radiation rooms that are popping up in London. This is for proton beam. Now, I don't know if anybody's seen the construction of a proton beam radiation room, but it looks like a mini CERN. Honestly, it really does. And it's incredibly dangerous. And the late Barbara Windsor was campaigning against them because, I mean, she lived in a fairly expensive street, I believe, in the centre of London, and they were going to put one just down the road from her, and she didn't want it. So we've got all of these labs, and how biosecure are these labs? What's going on in these labs? We know what goes on, or at least we think we know what goes on at places like Nibs and Porton Down, who are biosecurity for labs, high security. And I've been hearing, from the MHRA board meetings many times that things need to be tightened up a little bit when it comes to security and health and safety at these biolabs. So look around you in your neighbourhood and see what is springing up.
I mean, in Stevenage, there's one road that's supposed to be the industrial area. And, you've got places like MBDA, and you've got the people who produce the Mars probe and all sorts of high-tech stuff. And yet this is in the middle of a commercial, well, in the city centre, opposite to a swimming pool.
Wow. Well, I have to say, I was speaking to Dom and Christian Sheep Farm only a couple of weeks ago, and they were saying Cambridge, there were these buildings and laboratories and hospitals and clinics and all sorts just popping up everywhere. The United Kingdom is the global centre for life sciences. I mean, just think about the name, life sciences. That's your life, my life, and the science, pseudoscience. They've sold us out.
Well,
the NHS.
Think about the yellow card and how many people were showing us dying and having their life taken off them in there that they've done nothing about.
Yeah, exactly. I mean, what we learned at the MHRA board meeting, what we learn at every MHRA board meeting is that they all very much, they're all singing from the same page. They're all their master. They're all governed by one master, slapping each other on the back. They don't seem to have any interest in the public or public safety. And every single MHRA
safety at every other word. That's the thing that's frustrating.
Exactly. But, they drop crumbs. Loose lips sink ships. And even though they've got these smart, camera one, camera two signs, and it's all become a bit of a production now, they still slip up. So, I mean, I would say to people, if you're not watching the MHRA board meeting, yeah, it is a bit of it's not the most pleasant experience, but it's a good learning experience.
Should I just say about my question?
Oh, yes. Say about your question.
And
What
it
a good
was
place to
because
finish.
when I typed it all in, and it was quite near the end of the meeting, obviously, as soon as it went, Alison reacted. She obviously saw it because there was the kind of shaking of the head. And I think she typed something straight after. I think she told them not to answer it or not to bring it up. But I can't show any proof of that. It was just her body language when I'd sent and pressed the button.
I can verify actually that my question, when it went through, I asked her about an acronym she'd used and I just typed it in, and immediately she looked at the screen and she answered. She explained what the acronym was. So I mean, I don't know whether all of them within the room could see the comments. We're told they can't, but I'm pretty sure
Yeah,
they
but
can.
we used to be able,
She could.
but we
She
used
could.
to be able to write questions and see what the flow of conversation was. We
Yeah,
can't to do
it's
that anymore.
gone.
So
No,
I
that's
just
gone.
said, people have no confidence that if they have taken the trouble to fill in their details, registering an ADR, which may include death, that they believe there is no follow-up. You are talking of how to get more reports in, but people need to know what happens to them, especially with the death.
That it was never asked.
No. So
it was never asked.
yeah.
But what she does say is that you can just follow the little cartoon link that she sends in her acknowledgement email,
Just because
which tells patients the journey.
Just because they say they're doing this doesn't mean they are.
No, and they're not, and I don't know when the next meeting's going to be. They haven't put the date up yet. As soon as they put the date up, then obviously we're both going to be there. But
usually a couple of months, isn't it?
yeah, well, we were meant to have a meeting in December and that never got to that was cancelled at the last minute. There was no explanation. And of course, the November board meeting hasn't gone up yet. So they're sloppy, they're slack. There's a million words I could use for the MHRA. I'm sure people will be able to use their imagination.
All the analysis they use can be completely pulled to pieces.
Yeah.
I mean, they keep going and using the observed against expected.
Yeah.
Well, that's no good if you've never seen it before.
Well, I think maybe next time we have a chat, and it won't be long, everybody, because Cheryl and I have very regular chats. So we're going to be doing this very regularly. But I mean, next time, maybe we could talk about what is rare, because we've got rare side effects and how rare is rare, and it's fairly rare, severely rare. I mean, maybe we can talk about that. I mean, is there anything else you want to throw in before we say goodbye to everybody?
No, I think the thing we rare is a lot of these people who have got a reaction have not just got one thing. And if every one of them is rare, then rare times rare times rare is not rare anymore.
No, and it's not just mRNA that we need to be highlighting either. It's a whole load new genomic drugs, personalized medicine. Check your Ventolin inhaler, check your asthma inhaler, see what you're getting in your prescription. Has your box changed? Has the manufacturer changed? Have the ingredients changed? Because soon, the patient information leaflets that you can normally find in the box, and right at the end of the patient information leaflet in tiny, tiny, tiny print, you'll see the serious adverse reactions. Those are going to go because they want to put those online, or you can access it through the app. So you're not even going to get that luxury of having a patient information leaflet in your box. But I've noticed
when you're ill and you're having to take something, the last thing you'll do is go on your computer and look something up.
Exactly. But it is really important. Please check your patient information leaflet. Have a look at the box. See what manufacturer. Has your prescription changed? Are they using an alternative drug? Do you know what it is? Because I know somebody recently who received their asthma medication and they had a whole new inhaler they'd never seen before. And they were keen to take it up with the pharmacist, who actually didn't know what it was either, and had to open up the patient information leaflet.
The problem years ago when we had parallel importing. where they were bringing stuff in from other countries, and quite often the details were in the wrong language and it was all banned and what have you. But they're doing a similar thing again by just inflicting on people something completely different to what they're used to, which will have a different bioavailability. It'll all be different stuff. You know, I mean, June said, on witness at the inquiry, she said there was no difference between the different manufacturing processes for each of the vaccines. She was wrong. You know, and all these things react differently in a body because they're manufactured in a different way. And that's what we've got to guard against. But the mRNA in particular is going to be in every vaccine. It's going to be in your flu vaccine. It's going to be in a new vaccine. And it's going to be in these cancer vaccines when they're not vaccines, they're genetic therapies and haven't been trialed or tested properly.
And who else knows where it's going to be? They're talking about inhalation mRNA, you know, for asthma. They're talking about, I mean, we did see a piece, I think it was the American Senate, where they were talking about mRNA in lettuce, in tomatoes, you know, water. What's it going to be next?
Well, but it isn't in all the birds, aren't they?
Yeah, exactly. But, you know, mRNA, it's antivirals. It's monoclonal antibodies. It's the midazolam and the morphines. It's everything, anything that's coming down the pharmaceutical line right now. Please just check. Right. Where are we at then? Do you think we want to say goodbye to everybody now? Or do you think we've got anything else that we need to cheer up in with?
I think they'll be fed up of hearing that from us at this point.
Oh, they wouldn't. Would they? Cagney and Lacey, the Cagney and Lacey of the MHRA. No, well, I've got a message for the MHRA. If you're listening, MHRA, be very grateful if you could update your conflicts of interests online, including Professor Graham Cook's, who's the Fletcher Centre doesn't seem to be up there yet. So I'd like to see you refresh your conflicts of interests and answer our questions, Lawrence Talon. Dame June Rain didn't have the nerve to answer our questions. And you, Dr. Alison Cave, you haven't got the nerve to even let our questions be aired in public. Be ashamed, because we're going to carry on watching you, aren't we, Cheryl? We're not going to let them off the hook.
I'm waiting for the letter that comes as a reply from Alison that says they're unsafe and ineffective.
Oh, will that day ever happen? We're not going to give up on the MHRA. We're going to make sure that we hold them to account.
There's two ways of doing it, isn't there? There's having a go at them or there's informing people.
Yeah, and we're going to do both. We're going to do both because we can do both. And we have got a lot of more information to bring you. So hold tight, folks, because there is a part 3, and there will be a part 3 very soon, because we've had some information through that we're just trying to process. So give us a few days and then we'll jump back on and we'll break some news for you. But share this if you've enjoyed it. And Cheryl, where can everyone find you in the meantime on X?
You tested me again.
Yeah, I know.
At Cheryl Grainger with an I in it. 4.
Very good. And I'm at Debi with an I in it, Debi Evans Matron. So you can join us on X if you can't wait for the next episode, because we're always updating on X, and I've got a Substack too, so all of the links will be beneath this video. But if you've enjoyed it, share it, and Cheryl and I will be back very soon, won't we, Cheryl?
We will. We will. Goodbye from her.
And a goodbye from her. Bye.
Bye.